I'm now absolutely delighted to be joined by Doctors Michael Cookson and Adam Kibel. Gentlemen, welcome.
Yeah, pleasure.
Thank you very much indeed for joining us today. Now, you're releasing this week guidelines for the treatment of advanced prostate cancer. Tell us a bit about those guidelines and the process that you used to come up with them.
Well, it's been said that we're drowning in information, but we're starving for knowledge. And the challenge of the guidelines was really to come up with cull the review of the literature. There were over 5,000 articles to look into, and we distilled it down to about 300, and then using the panel we were able to sort those into evidence-based practical information for the clinician.
So this might sound like a little bit of a stupid question, but why come up with these guidelines?
5 years ago, there were no real treatments for patients with castrate-resistant prostate cancer. Now there are multiple treatments, and I think the clinicians are trying to figure out which patients to use which treatment and how to sequence them. In other words, which drug to use in which particular order. And we felt that at this point in time, it was appropriate to give urologists and medical oncologists a tool in which to evaluate the treatments and then use them in practice.
So what are some of the practical uses of these guidelines?
Well, I mean, we have index patients, 6 index patients that range from patients that have asymptomatic PSA rising in the setting of castration, all the way up to patients that are at end of life. And the clinician will be able to look at each different clinical scenario and say, okay, this is the recommended treatment for a patient with this particular clinical space.
And I want to add, what we did was we took the information and then we said, well, how would a clinician approach this? And so we looked at things such as, does the patient have metastases or not? How symptomatic are they? Have they received prior chemotherapy? And what's their performance status? And when we were able to do that, we took the levels of evidence and then put them into user-friendly clinical algorithms that'll be available both in print and on the web, so that the physician can quickly go to this guideline and then utilize the treatments that are available.
But in a way, this is good news, isn't it? Because there's so many more treatments exist now than they did 5 years ago.
Absolutely. As Dr. Kibel stated, before 2004, any treatment was simply palliative. Docetaxel, a chemotherapeutic agent, came along and it extended the life of men. These drugs can be used in combination or pre and post docetaxel to add additional length of life and the quality of life.
Gentlemen, thank you very much for appearing on AUA TV.
Thanks for having us.
Thanks for having us.